Good morning. Thank you very much for inviting me. And my topic today is football and benchmark figures. So I would very much like to thank you, Matthew, and Professor Worldbar for giving me the opportunity to be here and share information with you. A special thanks also to our CMO, Dr. Scott Gillogy, and the DG, Dr. Mohammed, for including me in the Aspetar advisory board. So it's not the first time I've been here. I've actually been here first time 2008, and we have this advisory board meeting once or twice every year. And you can see here from the right, it's Dr. Craig Purdam from Australia. It's Professor Antonio Belluccia from Italy, Professor K.M. Chang from Hong Kong, Dr. Tom Bess from the US, and Dr. Saleh Komba from Saudi Arabia. Now, already when we started in the advisory board, we heard that the ambitions were very high for Aspetar. We were informed that the ambition was for Aspetar to become one of the leading sports clinics in the world already in 2015. And we are impressed by the development of Aspetar. And personally, I would say that today I find Aspetar to be the leading sports clinic in the world. However, every leading organization will be scrutinized and will have to show facts. And this is an advice we have from the advisory board that it's very important now that Aspetar shows in facts and benchmark figures and in statistics and data that Aspetar is world leading, that the injuries treated here is world class, the surgery is top, the rehabilitation is better than anywhere else in the world, and that the preventive measures work. And this is something that we had a latest meeting only a month ago, and we heard that this is a work that is really ongoing, and this is very important. We also heard that we have understood that football is a specific topic for Aspetar, which the advisory board very much supports, and it's natural not only because football is the biggest sport in Qatar, it's also the biggest sport in the world, and you have the World Cup in 2022, but also for another reason, because football medicine is today leading the sports medicine development, and probably it's the money behind it. There's so much economy involved in the world football today, so this is the reason. Now, Matthew already told you my CV, and I can tell you if anyone wants to see a medal from a World Cup in football, I have this bronze medal from the US 94, and so I have some experience from the football field as well. I've been a football person and in football medicine all my life, and I would like to share some experience from this with you. The basic information I'm going to share with you today is from this injury study, which we have carried out at UEFA in Europe for 16 years now. We started already 2001, and the principle is that UEFA every year invites the 32 teams that qualify for the ground play in the European Champions League to participate in the study, and all the clubs participate in this study. As you can see here, all the best clubs in Europe send us data. Some clubs have sent us data every month for 16 years. We now also have clubs from South America, from Brazil, Argentina, Chile, and Ecuador. the teams do not send us data because they want to be nice to us or nice to UEFA. They do it because they get something back. What they get back is benchmark figures. Because in elite clubs today, they know the statistics of their own team, but they have no clue of the statistics of other teams. What we give them is benchmark. So we have reports which we send to them 3 times each year, and it's a lot of pages. What they can see is their figures for certain variables like re-injury rate, for example. And so one bar here is one club, and they can see their position in comparison to others. They can see the benchmark figure, which is the mean for all the teams. So they can clearly see what areas they are good in and what areas they need to work on. They can also follow the development of their own team over the seasons. So here is the mean for the Champions League, and here the bars are for this club for different seasons. And you could clearly see here when they have changed coaches, for example. So I would share with you some benchmark figures. And the first thing is, if you send out 35 pages, the people would always ask which figures are the most important, because they say, the medical team say, we have only 2 minutes with the manager, so we need to be concentrated. And the thing is that you need, from medical point of view, you need to present data to the coaching people and the administrative people that are of practical value. The basic thing in all these clubs is performance. So any medical thing that's related to performance is interesting. The most important medical thing that is clearly correlated to performance is availability of players at training and at matches. Because that we have shown and others have shown that this is directly correlated to performance for the team, which seems natural. You need to have players available to perform. The mean availability at matches in Champions League in Europe is 86%, so the unavailability is 14%. Now the unavailability is mainly due to injuries. There are other reasons, sickness, red cards and so on, but that's very, that's not of importance. So this is directly correlated to injuries. So we know that the benchmark is that you can expect about 50 time loss injuries each season, which is about 2 per injuries per player, if you have a squad of 25 to 28 players, which is the normal thing. Now, if you look at benchmark figures, you could say that the teams know that 14% is the mean, but they want to be better than that. So the best teams in Europe, they had a benchmark, what they're aiming for is 90% availability of players at matches. And you can see there is a variation here between clubs, but you can see there are actually 10 clubs in Europe that last season had an availability of players over 90%. And they are the teams that were successful that season. Here's one club in Europe which has a very high ambition. They have a definition of success for the team during a season, which is either winning the total Champions League or winning the league, or preferably both. So any season when they don't win the Champions League or don't win the league is a failure. And here you can see the match availability for players for this team during all these 16 seasons. And you can see here the mean availability for the Champions League in red here. And they only had, if you look at the 7 years where this team had an availability which was more than the average for Champions League teams. They had an 86% of success rate, and they won 2 Champions League titles. In the 8 years when they had availability which were similar or less to the average for UEFA, they had only 12% success rate, but they still won 1 Champions League title. So this is for the team and for the manager of that team a very convincing fact that it is important to keep the players on the pitch to avoid injuries. Now, as you all know, that whenever you have an athlete injured, there's always this question: when can he or she play again? And the good thing we have 24,000 injuries in the database, which is probably the world's largest, so homogeneous material of male professional football players. Now you get very robust data from that. So we are able to provide figures about the probability of absence for this specific injury. And these are benchmark data which are published and sent out to the clubs, and which of course can be used by anyone. Here's the list of the 10 most common injuries in male top professional football. And it constitutes more than half of all the injuries you see during a season. And you could see the number for each diagnosis. You could see the injuries per team per season. You could see the absence in days. And my recommendation, normally absence is published as the mean and standard deviation, which is not the best figure to look at if you want to predict absence, because the mean is you include the outliers, some that need surgery and so on, and you can see that from the standard deviation. It's much better to look at the median value. And if you look, for example, at the most common injury, hamstring muscle injuries, you see you have a median value of 14 days of absence. However, you all know that you need to be more specific than that. You have many types of hamstring muscle injuries, so you need to specify more, and you need a huge material to be able to have power enough to divide into other injuries. So if we look at hamstring injuries, you need to separate the hamstring injuries into severity grades. Normally at clubs, this is done by some sort of imaging, MRI or ultrasound. We did a study where we followed muscle injuries for 7 or 8 years in these clubs, and all of them were examined clinically, of course, that's the basics, but 86% were also examined by imaging for different reasons, but so they want to get some information out of it that could help predicting the absence, and grading into severity is important, because if you had a grade 0, which is no pathology on an MRI or ultrasound, they get back very quick. They have an absence of about a week. If you have a grade 1 injury, which is edema but no tear, they get back in about 2 weeks. If you have a grade 2 with partial tear, they get back in about 3 weeks. And if you have a total rupture, which is very rare in top-level football, it takes months. So these benchmark figures are to be found, and it's based on about 8,000 muscle injuries, or about 6,000 hamstring injuries. So it's a lot of material behind. You can also separate even more if you have such a big database. For example, you could separate between the different hamstring muscle injuries. You know that biceps femoris injuries are the most common, 83%. Semitendinosus and semimembranosus injuries are not so common. They have about the same absence days, probably because they are rehabilitated in a similar matter, but the re-injury rate is significantly different. It's a much higher re-injury risk with biceps femoris injuries compared to injuries to semimembranosus and semitendinosus. What the clubs do with this benchmark data is that they know that if we have a biceps femoris injury, be careful, maybe keep them a little longer in rehabilitation. If we have an injury to the semimembranosus or semitendinosus, maybe we can force them a little more. So that's how data is used. If you look at more at severe injuries with absence days more than 28 days, you could see, for example, meniscus injuries. I'm an orthopedic surgeon, and in my clinics, I think I did about 75% of my arthroscopic surgeries were to medial meniscus injuries. This is not the case in elite football. It's more common with a lateral meniscus rupture than with a medial, and the lateral takes longer time and has more complications. So be careful with the lateral meniscus injuries. You could see here they are more common than the medial. They have a median longer return to play, and they have a higher re-injury rate. So this is figures you can use as benchmark figures to compare your figures, what you have in your clinic and in your surgery and rehabilitation. An interesting finding is that sports hernia, for example, is not very common, but it has a problematic figure with re-injury and problems after the surgery, which is of some interest. We have published figures about ligament injuries and ankle sprains, MCL tears, and so on. So you can read in the literature, and here you can get benchmark figures. So it's easy to compare with the figures you have at Aspetar. Let's talk ACL injuries. I am an orthopedic surgeon, so I love to talk about ACL injuries, and I know that all orthopedic surgeons love ACL, talk about ACLs, and if you go to congresses, there's 75% of all presentations are about ACL and single bundle and double bundle and so on. Still, it's not very common. It's a severe injury. It's not really very common in football. It's less than 1% of all football injuries. It's compared to muscle injuries, it's a rare problem. You could have 15 or 16 muscle injuries on one ACL. You can expect to have one every second season for a team with 25 players. And of course, you know that the injury is more common in matches than in trainings. We had an opportunity to follow ACL injuries in our cohort. And in this cohort, we did not only include Champions League teams, we included also professional teams, males and females in Scandinavia, Sweden and Norway. And we found out that if you have ACL injuries, 97% were treated surgically. And those who were not treated surgically were the few partial ruptures. So you need a good function of an ACL to play football, at least at this level. 94% return to full elite level training within 10 months, 89% to matches within 12 months. All Champions League team players that we have in our study, and we have followed the best team for 16 years, we have about 100 or 120 ACL injuries in these teams. All of them have been operated on, and all of them have returned to matches, which is a fantastic figure. And we have a 4% re-rupture rate, which is the normal benchmark figure in the literature, as you know. This is a fantastic figure because you have, if you look at the ACL literature and in a mixed material, for example, here published from Norway, ACL verified injuries, only 49% return to sports. So here's a fantastic contrast between the figures we have published and, for example, those in Norway in a mixed material. Now the question is, who is right? I would say both are right, because this is what you get in a mixed material, but you get very different figures in elite material. So this gives a chance to see how can the treatment of elite level athletes be of any help to non-athletes. So you could ask a 94% return to elite level football after ACL injury. Is that a proof of possibilities through optimal caretaking, or is it a sign of knee abuse? Do they get arthrosis later? Is that good or not? The interesting thing is to see what are the factors behind a successful ACL treatment. Is it because they have an early diagnosis? We had they were all in our material, they had the diagnosis within the first week. And they, as you know, they use MRI and so on. So all of them were diagnosed within 8 days. Now, you know, in a mixed material, it could take several months before you get the diagnosis. Meanwhile, you have cartilage injuries, you have meniscus injuries, and so on. Is this important? What about timing of surgery? We know that, at least in my material, when I did ACL surgery, we normally waited till at least about 2 weeks or 3 weeks till the swelling had went down and the range of motion were restored by physiotherapy, because we know that if we operated a few days after the accident, they will be swollen and stiff, and they will have an increased risk of arthrofibrosis. Now, but on the other hand, what about if you operate before they get the swelling and stiffness? And this is normally not possible in a mixed material, because you have to discuss with the family, you have to plan your work, you have to, it's not, all of them do not want to have surgery. They need to plan for at least 6 or 8 months or so, and they need time for this. This is not the case with elite level players. They know if they have an ACL injury, they need to be operated on if they want to continue to play football. So some of them are operated already the same day before the swelling. Is this bad or is this good? I haven't seen any data of that. What about the experience and skill of the surgeon? That's what we normally say as surgeons, that it's very important that you are a skillful surgeon, you do many surgeries. Is this important? These players are sent to the best surgeons in the world. And when I talk to clubs, they say money is no problem, because they are so valuable. So they send them all over the world. So is this important? What about surgical technique? Is it important if you do hamstring graft or patella tendon graft or whatever? In Sweden, where I work, 90% of ACL surgeries are done with hamstring graft. But in our material here in Europe, about 50% are done with patella tendon, because some surgeons think that with patella tendon you get a little better stability. We don't know if this is important. Is it important with single or double bundle? We don't know that. What about rehabilitation? My personal opinion is that this is at least 50% of the success rate is depending on the rehabilitation. There's a huge difference in how these patients are rehabilitated and normally in a mixed material. When I did ACL surgery in Sweden, I wanted lots of physiotherapy, and I didn't accept physiotherapy in any physiotherapy clinic if they couldn't provide at least 3 times a week physiotherapy for the injured player. Now, in these clubs, they have 4 or 5 hours every day with an individual private physiotherapist who is a private PT who done the rehabilitation. How important is this? I haven't seen any studies showing this, but I personally think this is very important. What about mentality? I have seen several studies now talking about the importance of having a sort of confidence in the patient, self-efficacy, to believe that the result of your treatment and operation will be good. Now, I have to say that in Sweden, we thought that doctors should tell the patients about all complications that could be there. So we sort of scare the patients a little bit, say you can have a re-rupture, you can have infection, you can have thrombosis, and the physiotherapists they try to build it up again. Now these patients are very determined to go back to football. They know that most of them go back, and they have a mentality which are very much focused. How important is the mentality of the patient? We don't know. So I think that these are factors where there's a difference between elite level athletes and a mixed material. And I think that for ACL and other surgeries, sports medicine experience can teach something that could be of help in normal healthcare. What about overuse injuries? And you could see that they are not very common in football. Achilles tendon injuries for patella 1 and 2%. They have a very short rehabilitation. So normally they go back in a week or something, but they have a real problem with re-injuries. So this is a big problem in our material. And especially if you say that we define injury as time loss injuries, which is absence from full training a match. And we define a rehabilitation that a player is considered injured until the team medical staff allowed full participation in training and availability for match selection. So a re-injury is defined as an injury of the same type and the same site as the index injury, occurring within 2 months of the OK from the previous injury. This means that a re-injury is a failure. The medical team has said that now the player is ready, and obviously the player was not ready. So when you go back and see figures like that, you could say that you can in one way say the medical teams are lousy at predicting, and they are really have a high number of failures. This is, as you know, not really the reality, because the medical teams in elite clubs do not always decide the return day. It's the managers that could overrule the medical team, and this is very often done. And the players have their own opinion. Now, we have one member of our group who's playing in the Danish national female team, and she has done 120 caps. She's a physiotherapist. She did a study about Achilles tendinopathy. She showed that if you keep the players a little longer rehabilitation after an Achilles tendon injury, you get less re-injuries, significantly less re-injuries. And she had a cut of 10 days. Those who were back within 10 days, they have a significantly higher number of re-injuries, which is a problem because we know that re-injuries have longer absence than the index injury. So here's an advice to you in Aspetar. You will probably have a little problem in competing with the biggest clubs when it comes to return to play dates of ACL injuries and so on, because they work for 6 months with 4 or 5 hours every day. It's difficult for you to keep a player here 6 months and so on. But here's a niche you could take, because you could easily match these figures and have lower re-injury rate. So one advice could be, if you promote this and said, we could take care of your overuse injuries, and we have figures that show that we have much significantly less re-injury problems than they have in top European football and in the literature. So this is a recommendation where it would be easy to compete, because these figures are not good. Now, I have deliberately cut down my presentation in order to have questions from you or discussions for you. I have lots of other material to share with you, but I know that you are so experienced and you have so much experience. So I would love to have some interaction and some questions. But I have a question first for you. How many of you are on Twitter? Could you raise your hands? Less than half. I can tell you that this is a fantastic way of if you have any information, of sending out that information to lots of people and to get information quickly. So my recommendation is, if you want to be on the front line, at least in injuries, you should be on Twitter. And for example, here, if you have an information, you could have presentations like this with maybe 100 people or something, and you could write a paper and a few hundred read it. But if you have an information published on Twitter, it could be read by 100,000. So you spread your information. And I know that Rod is very active here, so you know what I'm talking about. So so this is a recommendation. So now I'm eager to hear your comments and your questions and suggestions of how we could continue and improve our study. Thank you very much.